I really want to thank you for allowing me to speak here. The occasion is not the happiest one. I'm giving here a memorial lecture for my partner and husband, Harvey Brenner, who passed away under rather tragic circumstances in a specialty hospital, in a heart hospital in Munich on September 20th of last year. And thus his death after 3 months in the hospital after a very successful bypass operation was due to a series of hospital errors, completely preventable hospital errors. And so my talk today takes basically his work and insights from his work to look at issues of preventable in-hospital mortality. And in terms of your system of complexity, I understand in-hospital mortality, especially post-surgery, as the moment in which an adverse event, a critical event occurs in which the system breaks down and criticality is suspended. And one of the questions is, what are the social economic factors that impinge on the survival or death of patients in the hospital? And yes, and of course, a related question would be, how can criticality be restored? So I'm going to start out with socioeconomic factors of complexity. Just make sure I can, trying to advance this. Good with that. Okay. All right. So so basically what I'm very interested in, and at the very end of the talk, I'll present statistical models of hospital mortality that are linked to causes of mortality and length of stay in hospitals. But first, I'd like to look at some of the risk factors. And some of these risk factors are along the lines of what our last speaker mentioned, but they focus more on contextual socioeconomic factors. So I already was speaking about how the issue of inpatient mortality can be considered as a breakdown of multiple components of the hospital systems that are not aligned or coordinated. On to the next. Here we go. So what are some of these risk factors? And in discussing these risk factors, I'm, of course, on the one hand, drawing from my basically witnessing. I do want to call this witnessing. I literally lived in the hospital for 2 months before I was evacuated because my questioning to physicians was considered an inconvenience, and then my visiting hours were restricted, and I was basically told I couldn't be asking questions anymore. So I'm going to be going over these points. One crucial point would be resource allocation to hospital concerning specialty hospitals, general hospitals, in terms of technology, nurses, physicians, but also infection control. I'll discuss this in more detail in a minute. Related to the resource allocation, in other words, how much resources from the gross national product does a country allocate in its hospitals is related to the question which age populations are worth living and which should be let go and die. Having some interference. Ma che cosa? Okay. That was an interesting background. Okay, so related to the issue of hospital resources is a really cruel, I would say, cruel and Darwinistic cost-benefit analysis. What is the ethical allocation of who survives and who should not be surviving in hospitals? And not only in the case of Harvey, but I think maybe in the case of Europe or Germany in general, there is the assumption that the population that's supposed to be supported are people up to their working age, up to 67, and anybody else can just be let go. In other words, there is an implicit age bias in the allocation that I'll be talking about. The other point I would like to mention is, and I'd like to preface this with a statement that we all love physicians. We all see the significance of teaching hospitals and physicians' trainings. And yet, having said that, there is a really problematic structure in which assistant residents are becoming decision makers in situations where they don't have access to senior physicians and make errors that have fatal outcomes. So I'll be talking a little bit about how physicians' trainings can, and this goes also along the lines of the previous speakers, involve patients becoming objects of training for knowledge that physicians in training will benefit from, but that may cost the lives of patients. And that is ethically unacceptable, especially if the deaths are preventable. And then lastly, I will present Harvey's modeling on the relationship of length of stay in a hospital and the mortality rates. And this is from a research project he did in Texas hospitals that hasn't been published yet. I should mention that Harvey was in the middle of books and various other projects that I hope to complete. Lack of research allocation to hospitals. So this goes along the economic front. One of the questions is, what are the national priorities for countries to control for, let's say, hospital-borne infections, superbugs that are impossible to treat? There is a very high mortality rate. And Harvey, in addition to E. coli in the heart wound and Candida, which is I forget the name, it also had contracted MRSA, which patients tend to pick up the longer they are in the hospital. There are very clear infection and prevention protocols, but it seems like Germany does really badly in terms of these. The other thing is there has been a tendency to turn public hospitals into for-profit models. And this means that the focus is less on patients, but increasingly on cost-saving measures that are, again, subject to an implicit Darwinistic cost-benefit analysis where only the working population can be invested in. In other words, there is a clear lack of investment, as in the specific hospital Harvey ended up. And if we had known, we would have gone back to the US, where life-saving treatment is not available, and that populations over 65 are especially at risk. Oh, goodness. How do I advance now? Else. All right, wonderful. Okay, so what are the ethical choices in the allocation of healthcare resources? There is a problematic distribution of life-sustaining societal resources, and this is a discussion that societies should have. Illness severities, of course, ought to be the key criterion in the life-saving capacity of healthcare over the lifespan. if such policies were enacted, older populations, given the current technology, would benefit. However, I want to argue age bias in hospitals and healthcare institutions in Germany prevents life-preserving effects after age 65. And so there is an implicit strong age bias in hospitals, and we were already talking about the cost-benefit analysis, the adequate lack of care, significant barriers to care. I can just say in Harvey's case, this was a heart hospital that had no physicians in interior medicine, no infectious disease people once he contracted the infections, nobody in pulmonology, no psychiatrists, and it had instituted barriers to care by basically making any consultations with other hospital subjects to board approval, and that never will happen, right? Because by the time the board meets, the patient is dead. So, and this clearly is a link to the for-profit model, but also to the assumption that older populations, which are likely to contract infections, are less valuable to society, are supposedly less productive, and hence don't need to be kept alive. They are expendable. So what would be required is an investment in healthcare resources. So I do want to foreground the next comment by saying that, I completely believe in physicians. I support the significance of physicians training. However, I also would like sensitivity workshops to be taking place in which physicians in training engage in something called critical self-reflection in their relationship to the patients, so that patients are, whether they're conscious or not, are treated with respect and dignity and don't become involved in a process of dehumanizing experiments. My experience has been, unfortunately, that low-level, inexperienced residents who didn't have the expert knowledge were basically, due to issues of social class and hierarchy, posturing a knowledge they didn't have to fill it in. And in this medical posturing towards the patient, but also towards the family, they made horrific, irreversible errors. And as I just mentioned, pointing out these errors is not being rewarded, but my visiting hours got cut and I basically was sent home, although my concerns about errors turned out to be true. So this is a slide where patients, and I know this is a sensitive issue, are being turned into, from my perspective, into objects of experiment. And that's not what we want to have. What would be required would be an active listening to patients' medical needs, a kind of humility in admitting what physicians do not know, cannot know, but participate with family members in doing their best. Next is a study that Harvey had done on the impact of hospital economic resources and patient safety and hospital mortality. This is from a database that uses public use data. And what it is showing for the years, 26 over a 6-year period to 2011, on the left-hand side is the proportion of inpatient mortality. And on the right-hand side, it's showing for the 5 most important causes of death after admission, what is happening. So let me just quickly go over the causes of death. The yellow one is sepsis. The blue line is ischemic stroke and precerebral occlusion. And then these other lines are pneumonia and heart failure and acute myocardial infarction, which it's a heart attack. So you see on the first day, the mortality, I should say that this data has been adjusted for severity of mortality, age, and demographics, and it's published by 3Ms, these specific, we see that the hospital mortality is highest on the first day, then goes down on days 2 and 4, and seems to be, at least for sepsis, lowest on days 5 and 7. But then it actually starts rising again. So the longer the patient is in the hospital after day 8, the more the risk of death increases. And this is actually, so it's a U-shaped curve, and this model is nonlinear. Clearly, what's also very interesting is that it calls into question the prevalent models of inpatient mortality. And Harvey was about to study this with a patient safety officer at Baylor Scott and White, but it didn't get to this. So I hope to include it in the book. So I found this rather interesting. In summary, maybe I can go back. Oh no. In summary, so the question is, how can criticality in the hospital care system be restored in ways that prevent adverse events and medical errors to ensure patient survival, right? And it's clear that in order to restore a system of criticality, integration and alignment of the various social, economic, medical factors, and I would add, of course, the factor of spirituality, of inpatient mortality would be required, including length of stay, the issue of investment in hospital resources, address head-on the question of age bias, the lack of infection control, which is an issue of national priority or not, and a lot of the public may not be informed about it, and the social risk factors of physician behavior that translate into medical errors, right? So in terms of a point list, what would be required is a significant increase in resource allocation, removing barriers to critical care, a discussion about the implicit Darwinistic age bias of the medical system, and a discussion about what is the value of older populations to society, and a discussion of how the intersecting spheres of the economic, social, and medical complexity ensure the survival of patients in the hospital setting. In other words, we do need an approach that accounts for the involving complexity of patient safety in the hospital setting so that patients are not subject to hospital errors. Thank you very much. Thank you. Yeah, April.
Hi, so I have a question about, are you familiar with any of the research about, say, cultures or countries that tend towards a more strong appreciation of older people? And more often than not, I think those are countries or cultures that have fewer resources for hospitals, but perhaps their outcomes may be different. Do you know?
Yeah, the WHO basically, okay, so there is a measure called years of life lost, and that measure actually is inherently deeply problematic because it's being purported by the WHO, and the goal is to achieve life expectancy in the countries that you often mention, often third world countries, India or China, and the cutoff point is 70, right? So livable and sustainable, quote unquote, old age or elderly is 70, so no resources would be provided to ensure survival of older populations beyond 70, which in and of itself is deeply problematic.